Thank you, Sealer. Are they are there? Okay. So they have given us this machine. So this is a new anesthesia machine which I think they have introduced. Couple of things I would like to discuss here and show you. One thing is that the pre-test. Okay. So can we get the sealer person? Okay. Meanwhile, they have done a pre-test and they have identified the leak part, which was not very high. But how to check it manually? So for the manual checking, there are there are two important points. Okay. What you need is a two bag. Okay. It is called two bag test. You start the flow at 5 liter. Okay. Oxygen khula hai na? You start the flow at 5 liter. Squeeze both the bag. Okay. Now this will help in what? To identify that both unidirectional valves are functioning. It is very, very important that there are many times you might have seen those who are senior and those who have worked since a very long time that it gets stuck. Okay. So it is very, very important that before starting, after even doing a pre-test, this is something which you can always do. Close APL wala bit and try to squeeze both the bag. So this is called two bag test. Now to check whether this machine has leak or not, we have to switch it to the ventilator mode. So we have made the flow at 5 liter. Okay. And then I'll switch to IPPV. So there is a leak and it is not showing. I have immediately identified the leak. So the ventilation was not working. Okay. So ventilation should work efficiently. No flush on patient. But just to raise this right now. Okay. If there is no leak, this should work. The bellows should go down and it should not remain low. It should achieve the height. Now to quantify the leak, suppose if you do not have tests and you want to know how much leak it is because you want to use low flow and you want to know exactly how much leak it is, you can gradually go down on the flow. So what you do is to reduce the flow. Sorry. Keep it 4. Okay. It is still achieving the full height. It is not going down. So the leak is less than 4 liter. If you can zoom it here, this part, don't need to show me. ये दिखाओ, ये part. So I'm keeping it 3. So gradually you go down on the flow. Okay. And our target for low flow anesthesia is 200 ml. So we should take it down to the 200 ml. And check whether it is working or not. Okay. So it is working well. Right. So there is leak is less than 200 ml. If there is any form of leak, the leak is there now. Okay. Increase करो 1 liter करो 1 liter. Do not flush. Okay, bellows have gone down. Do not flush. I have created the leak. The reason behind this is that I have created the leak, and that is why we are not getting the bellows up. Okay. So what you need to do to get bellows up is to increase the flow. Okay. Do not use flush. I have created a partial leak right now. Okay. So you can quantify this leak. If there is a small leak in your system by gradually reducing your flow, and at what flow this stops achieving the proper height. is a way of checking it if you do not have proper pre-test. Okay. Now another important point, do you check this, right? 300 tidal volume जा रहा है, 400 जा रहा है. This is absolutely useless. Okay. Absolutely useless. It is not needed and it doesn't give you correct value. Okay. Let me tell you. The target, this is still 500. Okay. It is just showing 300. Okay. So the bellows movement depends upon the flow which you are setting, and this value is absolutely not relevant. So don't use this value to identify that how much tidal volume is given. It is part of a standard requirement, so they are writing it, but it is not useful. If you increase flow, it will change immediately. It will start showing low. So even if we are targeting giving 500 tidal volume, it will not show 500 because machine is giving less now. To keep this at 500, when I am increasing the flow, it is reducing the bellow movement. If I am taking it down, the fresh gas flow goes down and the machine, the bellows required to produce this particular gas, so it will move more. Okay, so this is fresh gas decompensation. And let me see what is the effect which we get. Okay. Can you show this part? इधर दिखाओ ऊपर. हाँ ठीक है. Okay. Let me press flush. And let's see how it behaves. नहीं नहीं, ये आप यहीं पे दिखाओ, चलेगा. $876. So if you press flush while patient is connected, this is going to give you higher tidal volume. Immediately within next one breath, it is taking it back to 509. So that technology is good. But if you press flush, you are going to deliver higher tidal volume. It definitely increases. Okay, now this has a reasonably good compensation system. So minor change in the flow does not give you much difference in the value. Okay. It will slightly increase it and taking it back. But if you give large volume, it will definitely increases the flow. Okay. Okay. All of you have seen and understood Plateau pressure, right? Now Plateau pressure is our darling. हमको Plateau pressure पे ही work करना है. How do you get the Plateau pressure? आप कैसे लाते हो? From how do you get the Plateau pressure? Is it showing right now? No, IPPV only it will show the Plateau pressure. No. So do you know how to get the Plateau pressure? If you have a GE machines or machines like this, if you have a dragger machine, it straight away gives you a Plateau pressure. The reason behind that is that you need to give pause in your inspiration. So unless you give that pause, you don't get that Plateau pressure. So here, I think this is the pause, na? नीचे अपेक्ष. Yeah. This 10%. Okay. So on an average, most of the machine gives you 10%, the pause value, which should actually change the graph. Okay. Now here graph is actually nearly flat. But otherwise, the peak, it should go to the peak, settle down to a slightly different value, which is your Plateau pressure, and then it should come down. If you remove this Plateau, okay, this probably the flat part, top flat part will go away. It has become sharp. So to get Plateau pressure, which we really want for the driving pressure and the lung protective ventilation, you need to apply pause, which is not a default what you call values or the default changes in most of the machines. So you need to really add it to get the Plateau pressure. And most of the machines keep 10%. Though there is no clear, I would say, numbers that okay, 10 would work, 20 would work, or 30 would work. But 10 to 20 would be probably a reasonable percentage. So that much percentage, there is a pause at the end of a peak pressure. Okay. Now, this is a volume mode. Okay. In volume mode, the pressure increases. Okay. And the flow is. Anu, Pelu, can you get me the, what do you call? Any range and 122 ochi thase? Okay, fine. What I wanted to show was what Dr. Bandari said. The flow is constant in volume control, what do you call, mode of ventilation, and the pressure increases. So volume is fixed and the pressure keeps on rising depending upon the patient's lung compliance and the system's resistance. Now, what is a controlled ventilation? Pressure controlled ventilation? The pressure is constant and it is achieved by a very high flow initially. So right now, probably in this flow pattern, what the machine's flow rate which is delivered, can you close up here this part? Okay, so this would be roughly 15-20 liter. That's a peak flow rate. Okay, now when we change over to pressure control ventilation, and right now the peak pressure is 23, PEEP is 3. So let us put the pressure control ventilation, and the target is 23. Okay, perfect. Let me put it. Can you see the rise in the flow? The pressure control ventilation delivers very high flow initially. Okay, it has started giving more than 60 liter flow initially, and then it just needs to maintain that pressure. The idea is to have a pressure which is maintained. So it is called decelerating flow type of pattern, because it delivers higher flow rate initially, and then it gradually reduces because it is just maintaining that pressure for that particular time. So when you compare volume control with pressure control at similar peak pressure, pressure control is likely to deliver higher tidal volume. Because it is generating higher peak flow rate initially, it is likely to generate better tidal volume. So we want pressure control, right? कम pressure में अच्छा ventilation हो जाता है. But in many situations like laparoscopy, obesity, changing compliance, like when they do pneumoperitoneum, the pressure keeps on varying, which we also don't want. We also want a proper constant tidal volume also. So for that, now there is a newer mode which is called the PCV VG. Okay. Now this is volume guaranteed mode. Some of machines they call volume autoflow. Nothing, I'm just explaining. Volume autoflow. So we consider that it is a controlled ventilation with autoflow. They are basically pressure controlled type of mode with volume guaranteed within the specific range of airway pressures. So up to 35 it will try to give you your tidal volume. So what it will do? So we'll change to PCV VG now. When you change to PCVG, we have set 560. Okay. So when I'll change over, it will take probably a control mode first. Once it is giving control mode and identifying the compliance, it will start getting it there. Now, since this is not an actual lung, but it will gradually improve the tidal volume with changing in the flow, and it will get you to your targeted tidal volume with the optimum flow and the pressure. So, when there is a situation of varying compliance, the best mode would be the volume guaranteed modes. So, if you have volume guaranteed modes, it is basically a pressure controlled type of ventilation with guarantee of tidal volume within a specified range. So if your peak pressures goes more than 35, it will tell you, okay, the peak pressures have gone up, I am not able to give you tidal volume, and then you need to work on that particular point. So this is pressure volume guaranteed modes, which are really, I would say, the best mode if it is available, because it is best of both the world. It is giving us volume guarantee, and it is also the pressure control type of ventilation, which is a better flow pattern. Another thing which we were discussing in the afternoon was this expiratory pause. Okay, so here the expiration ends here, and then this part, okay, is actually unnecessary. In actual lung, this is too long, and which can be reasons for atelectasis. So this can be minimized by changing in the inspiratory time. So you increase the inspiratory time, okay, make it lower, though because this is a test lung or a bag, it will not behave the way it is in patient, but it will definitely increase the inspiratory time, and by that it will reduce the expiratory time. So your expiratory pause can be reduced. So unless contraindicated, like a very tachypneic patient or a pediatric patient where you need slightly, or a COPD patient where you need slightly longer expiratory time, your ratio has to be 1:1. You don't need 1:2. If this expiration is prolonging and developing the autopeep, then only you need to increase the expiratory time. Otherwise, 1:1 would work well, and it will reduce chances of atelectasis because you are reducing the expiratory pause part. Can you show the test data, self-test? Every time when you are checking, the self-test will actually take you through that entire process, including vaporizer check. But if it is not there, in that two-back test which we have discussed, you should also open the vaporizer and check when you are using with the ventilator, that whether is there any particular leak, because very commonly we tend to forget this, we keep it open, this lead, and there is a leak. So you should also open the vaporizer while that ventilator is working in the two-back test. So basically it will test everything, leak, compliance, and it will give us the information. So meanwhile this is happening, if you have any queries about machine, we can solve or discuss, because in this part I think everyone has their experience and knowledge. So if you have any particular query, if you have any particular idea, if you have any particular suggestion, we can discuss while this is done. So I think modern all anesthesia machine, you can change the canister, right? We can change the canister. Now most of them, when you remove, there is a diaphragm. Yeah, during the surgery also they have a diaphragm, so you can remove, but you need to increase the flow. Okay, unless you increase the flow, you cannot remove it. Some of older machines, it was not possible. There will be complete loss of ventilation. 2-minute ventilation. Yeah, it's open circuit basically. So actually it takes you to entire process of manual checking also. So they check the internal system, they'll check the ventilator, it will check the circuit also. So I've created the leak and we'll see what it does actually. Which is a very common scenario when you tend to, get these things remains open. So basically, I would still go ahead with the volume guaranteed mode, which is a pressure control type of ventilation, which is likely to deliver better tidal volume. Okay. I will definitely go ahead with the pre-oxygenation with CPAP. I will recruit the lung. I will continue with the PEEP. And if required, mostly if patient has COPD, then I would have to keep my expiratory time longer. So I will check that waveform whether my CO2, what you call expiration, is getting completed or not. If it is not getting completed, I will increase the expiration time. I ratio, so the I ratio would be even 2.5 also. It depends because you have a flow pattern, okay, which tells you whether your expiration is ending or not. Now, expiration is absolutely passive. In anesthesia, in our anesthesia ventilation, inspiration is active. Okay, expiration is done by lung itself. We do not have any role. So we'll have to find out how that particular lung is behaving, and it should reach the baseline. If it is not reaching the baseline, I'll have to increase this time, use bronchodilator. Okay. The other methods, extreme head low.
Extreme head low, these are already obese patients. Though they don't have per se COPD, but airway pressure will be already on higher side and the duration of surgery is long. In such patients, it is very difficult to maintain the tidal volume and also maintain the lower airway pressure. So how do you manage those patients?
Suppose you are using volume control mode. Fine. And airway pressure is going beyond 30. So you need to control the airway pressure. Fine. So how to control the airway pressure first? So suppose you kept 12 rate per minute and set the tidal volume of with the volume control 400. 5 seconds of breath. So when you are keeping I ratio 1:2, so 2 seconds is for a inspiration. Suppose 6 seconds of breath, 4 seconds is a expiration. So you are getting 2 seconds to deliver 400 ml. That increases the airway pressure. But if you change the I ratio 1:1, now you will get 3 seconds to deliver 400 ml. So that automatically stabilizes the airway pressure. So this is how you can do. Third thing, this is second thing, what you can do, you can increase the peak inspirative flow rate. So in a limited time, you will get higher tidal volume delivery. So pressure will be yes. So if it is possible to increase the peak inspirative flow rate, normal inspirative flow rate is set at 30 liter per minute. If you increase to 50 liter, so that machine will deliver in 2 seconds. Initially it was delivering 30 liter. Now it will deliver 50 liter. So you can achieve tidal volume with the limiting pressure.
That is, I think, this changing the peak flow rate.
What your suggestion, Dr. Dheeraj, for this? It is not possible in all machine.
But dragger machines it is possible. Baki not in all machines.
Yeah. So what should be the driving force? That is driving pressure. So your patient should not have, in normal cases, it should be 13. Means Plateau minus PEEP should not exceed 13. 1-3. That is normal. If it is required to, if it is increasing, you can accept specifically in left surgery, obesity, robotic surgery up to 20, not beyond that. Now is time your driving force is exceeding 20. Fine. So then you need to, you have to control beyond 20 and accept permissible hypercapnia. Don't increase the driving, don't try to manipulate the driving forces beyond 20. At that, don't manipulate the ventilation, accept the hypercapnia up to the 55. I am accepting up to the 60 many times, depending on the patient conditions. But when we are recovering that patient, when surgery gets over, we'll make it sure that end tidal CO2 remains 30-35. So we'll continue ventilating even if surgery gets over. We'll get the ETCO to 30-35. We'll get the EBG done. If it is normal, then we are extubating. Once abdomen is deflated, you can do that. But another important thing, when you are ventilating a patient, keep the driving force around 13, not beyond that.
pH becomes very important, and which we, I think, don't do it very routinely. So if our pH is within an acceptable limit of 7.25, and even if my carbon dioxide are say 50-55, I will accept it, isn't it, sir? And once the surgery is done, then the idea is that ultimately the pH is something which makes a more important role rather than the carbon dioxide % number itself.
So we are trying to do test, okay, and I've created the leak by opening this, partially closing with a tape. So there was a leak. Can you show this? I don't know whether you will be able to. So basically what it shows right now, I'll just tell you that the compliance is 6 ml per centimeter of H2O. Okay, so that's the compliance, and it has to compensate for that compliance part, 6 ml.
What is the clinical significance of that compliance? 6 ml per centimeter of H2O. So, which each centimeter rise?
So 10 peak pressure, 60 ml is lost in the system.
In the circuit expansion. So, if your airway pressure exceeding 20, so 20 into 6 means 120 ml is getting wasted into the circuit expansion. So, that's the importance of measuring the circuit compliance.
Okay, and the leakage it shows is 1000 ml. Okay, which is not acceptable. So it was showing the failed test. Now, if you bypass it, then you can completely miss that particular part. So, important message for everyone, those who are in practice, those who are in postgraduate students, do it yourself and do not bypass it. So, this is one which I wanted to show, this part, okay. This is called econometer. Now, this tells you about efficiency of your low flow anesthesia. If you give very high flow, it will remain in the upper part, okay, this part. So, you know that you are not very efficient. When you reduce your flow and when it is efficiently used, it will come into this particular zone. So, it gives you a visual guide whether you are efficiently using the low flow anesthesia or not. So this is an additional tool which is sort of a software basically. So it is a software which is available in most of the now advanced anesthesia machine in one or other form, which tells you that okay, your low flow anesthesia is okay. So the moment you go beyond 2 liter, it will reach here up only. When you are around 1, it will start coming down. And of course, if you go to 0.5 and if it is efficient, it will remain here. But if you are using low, okay, if you are really reducing the flow very much less than your oxygen consumption, and then it will go down to red. And it will tell you that, okay, you are giving insufficient flow. So that's an advantage of almost all companies have one or other way of doing it. I think that's all. If you have any queries, we can still solve it. Or we can discuss it.
Sir, on the ventilator, we always see that expired tidal volume. So, what must be the acceptable difference between delivered tidal volume and expired tidal volume?
So, rather than deliver, it's a set tidal volume and expired tidal volume. Always rely upon the expired tidal volume. Don't rely upon the set tidal volume.
No, if it is, I would say 5 to 10% range is okay. So you set 500, it might give you 490 to 510 or 520. That seems to be okay. Okay. But if it is beyond that, and it will show if you are giving very high flow. Okay. When you are giving very high flow, okay, then basically the oxygen flow which is more than patient's requirement will also go to the expiratory limb, okay, because the flow is constant, and then the ventilator might sense slightly higher tidal volume. So it's 10% range is okay. If it is slightly more or equal to the delivered tidal volume, we are very happy. If there is a too much of difference, say if it is 500 you have set and if it is giving 400, then we should really worry about it. So if you are keeping low flow, your set is 500, it might show 490. If you use higher flow, your set 500, it might show 510. It can show higher. It is not abnormal. That there is nothing wrong with the machine.
But you should rely on the expire then delivered.
Yes.
So we talked about this lung protective ventilation. So many a times, even if you have a tidal volume of say around 350 with a respiratory rate of maybe 16 to 18, still the EtCO2 is below 30, 26, 24. So for a patient of 50 kg weight, we think that 300 will be too much, too less tidal volume. So whether it is a problem of EtCO2 calibration, and if it is the problem of EtCO2 calibration, how do we diagnose? Or shall we reduce the ventilation further, or we should calibrate the EtCO2?
The important thing, when you are setting up the ventilator, you should rely on the EtCO2. EtCO2 is a good guidance for setting up the ventilative parameter. Fine. So usually, if your driving force is within limits, 13 centimeter of S2O, and if you are getting less tidal volume, but if you are getting good EtCO2 and good sp2, that is fine. That is suggestive of good gas exchange. But at same time, your EtCO2 should be properly calibrated.
No,
It's a self-calibration is happening every time, mostly. Most of the EtCO2 machine. So, with the high tidal volume.
And low tidal volume.
See, yes. So, with the prolonged surgery, if tissue perfusion is compromised with hypotension, suppose there is no hypotension but hypothermia, that can lead to low EtCO2. That is one. What?
Yes, sir. Second thing is, sir, about the gradient.
Gradient.
Suppose if it's a
Perfusion
32,
true.
and if the gradient we are accepting, sir, if the patient is not in shock state or something, we will take a gradient of 5, so that is okay. And then the third is range of tidal volume. We are starting from 6 to 8 ml. But if you look into the ARDS ventilation especially, people have gone up to almost 4 ml per kg. But for our normal lung, it doesn't make a great deal of difference. Once in a while, what they say is, every machine does a zero calibration, and once in a while, whenever facility is available, because if you have a capnograph, you should correspond once in a while with the ABG values. So that PaCO2 and PEtCO2, if that corresponds once in a while, you can be happy that okay, this is my okay. And suppose ICP pressures are there, trauma patients are there, keeping a low EtCO2 is dangerous, then we'll probably have to do the needful, sir.
So now, what is predicted tidal volume? See, important, you should deliver 4 to 6 ml per kg, not ideal body weight, not actual body weight. It should be predicted body weight. Now, what is predicted body weight? What is predicted? What? So, predicted body weight for a male is 0.5, 50, 50 plus 0.9 into height of the patient minus 152. Height in centimeter minus 152. So we'll calculate. We'll 50 plus 0.9 into height, and for easy calculation we'll keep 150. Will not keep 152. Suppose most of the Indian adults are ranging from 5 feet to 6 feet. Fine. So 99% of the adult patient will between the 5 feet and 6 feet. 5 feet means height 150. Fine. So 50 plus 0.9 into 150 minus 150. 50 plus 0. 0.9 into 50. 50 plus 0. 150 minus 150 is 0. 0 into 0.9 is 0. Fine. So 50. So predicted body weight for a 5 feet height is 50 and 6 ml per kg 50 is. So lowest for an Indian patient, lowest tidal volume, keep it at around 300. Now we'll calculate the highest. So you'll get a calculation के 5 feet या 6 feet है इतने से बाहर नहीं जाना चाहिए patient. So 50 plus 0.9, 180 minus 150, that is 6 feet 180. 180 minus 150, 30. 30 into 0.9, 27. 27 plus 50. 77. 77 into 6. 420 plus 4, 460. So, whether you are handling a patient between 5 to 6 feet, your tidal volume range is 300 to 460. Now, whatever the patient weight is a height dependent criteria. So, whether you are conducting a case of 150 kg or 200 kg or 250 kg or 300 kg, your tidal volume should not exceed 460 if height is less than 6 feet. Whatever it is, your tidal volume should not exceed 460. So, simple sense, from 5 feet to 6 feet, 300 to 460. So, if you need to deliver higher tidal volume, think twice before delivering.